All right. Good morning, everybody. Happy Friday. On behalf of the Colorado Cancer Screening Program and partners, I'd love to introduce or actually welcome you all to our day as we launch our annual meeting for our statewide program with our staff, our partners in Colorado, as well as people external to Colorado to talk a little bit about the work of the program, where we're going, and then, of course, all of the resources and opportunities for partners who are part of CCSP, as well as the greater network for cancer prevention in Colorado. I'm Andy Dwyer. I am the director of the CCSP program from University of Colorado Cancer Center, Colorado School of Public Health. I work jointly also in helping fight colorectal cancer in terms of advising around the research patient education aims. And really excited to launch today, talking a little bit about where we are, where we're going, and then hearing again from our partner network about the resources and opportunities moving ahead. So we will go ahead and get started in just a sec. We've had just a little bit of a minor technical difficulty with some slides this morning. But just to give a bit of an overview of the run of show for today, we will be hearing from our leading experts in cancer prevention and control, Dr. Swati Patel, Dr. Debbie Dyer, Melissa Gilstrup, as well as Emily Kinsella. We'll be sharing perspectives related to colorectal cancer, lung cancer screening, genetic hereditary screening, as well as updates in breast and cervical in our partner program, the CPED program in the state. So I'm really excited. As you all know, there have been some great advancements and developments in the last couple of weeks, particularly for guidelines for average risk population for lung cancer screening and colorectal screening. So the timing couldn't be better. We're also going to be hearing from Angie Davis, who is the president of Fight Colorectal Cancer, who's going to be giving some national perspective. And then hearing again from many of our partners from the Health Department, American Cancer Society, CCHN, the Colorado Rural Health Center, Cancer Coalition, and others are sharing perspective about the direction, resources available to really augment our work moving ahead. So super excited about having you all today. Representative Harry Will is going to be joining us. But he actually has several different bills that are on the floor right now, but wants to send his support of our ongoing efforts related to access to care in terms of the screening prevention control initiatives. So I do have a little bit of a cold / stuffy nose today with allergies, which I'm sure many of you can appreciate. So bear with me, and my camera can be a little temperamental, but we're super excited. Erin, do we have our slides up ready yet here? I'm not sure where we are with our slides really quickly. While we're bringing up our slides and getting ready to go, Elsa, I don't know if you have control of those. Angie Davis, to kick us off this morning, I'm going to give some perspective about the program and data. But as we're getting ready to pull that up, Angie, would you like to, I'd love to introduce you and have you go ahead and share some perspective from the national level, if you're okay with that. President Davis, are you good with that?
That sounds great.
Okay, good. We're a little bit out of order just in terms of the slides. So all of you, many of you know Angie and Fight Colorectal Cancer and the great work that they've contributed in terms of helping advance the agenda based on research, policy, as well as patient support services. And they've been a great friend to Colorado, as many states. We've worked on several different initiatives, including some policy initiatives in Colorado. But I wanted to have Angie join us today to talk a little bit about really where we're going in terms of the national perspective, as well as really how Colorado has been engaged in this work, and I think can be a partner in the national movement in terms of cancer prevention moving ahead. So Angie, I'll turn it over to you.
Sure, thank you. So I don't have any slides today, but I'm going to be fairly brief, but give you some insight into what we're doing here at Fight Colorectal Cancer, our partnerships with CU and members of the state of Colorado, and then also obviously I'm very excited this week around the drop-in screening agent. I'm sure Swati will get into the details of that. So for those of you who are, I think many of you are familiar with Fight Colorectal Cancer, but I don't know that everyone on this call I've met. Fight Colorectal Cancer is a national advocacy organization. We're focused on awareness and education, as well as policy change, empowering advocates and tooling them with information about state and federal policy efforts to improve access to screening, access to care, and increasing colorectal cancer budgets within the NCI, CDC, and DoD. In addition to that, we have a research effort that Andy mentioned she's a partner and advisor with. We train and empower research advocates, as well as funding and convening research scientists around the country and globally. And we've been able to work with many partners in Colorado who've supported that program. So that's been really exciting. On the policy front specifically, we have our federal efforts, which right now have been very focused on the DoD and increasing colorectal cancer funding through the DoD peer-reviewed research program. On the state level, we have a program called the Catalyst Program, which is a state effort to empower grassroots advocates and to fund state coalitions that are working in colorectal cancer and trying to increase colorectal cancer screening and awareness in their states. Colorado was one of those awardees. Fortunately, we were able to quickly fund Colorado because of the momentum that was happening, and sort of cut our teeth on our first Catalyst grant. And so we really saw and learned how coalitions work within the states and the momentum. And I just want to sort of applaud the work that Colorado led in reducing barriers to colorectal cancer screening. And that's the one thing that we see within our grassroots policy efforts. It's 100% a long game and a long-term partnership, and that it's not always easy to just build your coalitions and hope that legislation will pass within the first run or second run and possibly third run. So we really are seeing our Catalyst program as a long-term relationship and opportunity to work with states. And one of the key things within the Catalyst program is we were able to work with Christy and team to build an action plan, look at evaluation, and then look at how can we build champions within the state. And so I really want to say that Christy, you did a great job really kind of shepherding that process and working very closely with your coalition. I know Becky was involved in that and many others on this call. As it relates to the Catalyst program, we're really excited about the 45 screening age and the drop in 45. We'll be working very closely with states to ensure that insurers and payers are supporting the screening age drop to 45. And in addition to that, we want to make sure that the follow-up colonoscopy, if a non-invasive screening test is provided, is also covered as the full spectrum of screening. That's something that's come up several times within many states. We've been able to fund 8 Catalyst grant awardees. And now as we go into the second iteration of Catalyst, we're really looking at that follow-up colonoscopy coverage. And just to provide a little bit of thought behind that is that we know non-invasive screening tests after COVID is a mode of screening that many groups are looking at. And so we want to make sure if that is a strategy that a FQHC or a clinic is using, that follow-up colonoscopy is covered, because that continues to be a financial barrier for those who are seeking screening. And I think with COVID and sort of uncertainty and capacity in certain communities, it's incredibly important. In addition to that, navigation, we're keeping a keen eye on navigation. Colorado has been one of those states that have led the charge in developing best practices around screening navigation. And so we really want to be working with states and looking at states to make sure that navigation is funded and supported. And if there are opportunities for us to not only facilitate payment of screening services, but also the services that make compliance and support for the patient to get screened is very important to us from a policy standpoint. So we're looking at that both from a federal and state policy effort. So I know that you all will be covering a lot of topics today as it relates to colorectal cancer screening, lung cancer, and breast and cervical as well, I'm sure. But for colorectal cancer, I think it's been an area that Fight Colorectal Cancer wants to make sure that the advocacy voice and the patient voice is aligned with the research efforts and public health efforts. So we're doing our best to work with the CDC, ACSCAN, Prevent Cancer Foundation, and our state partners across the country to make sure that we're providing tools, resources, briefing pages, samples of policy for states to reference, and then also trying to make sure that our federal efforts are aligned with state legislation and making sure we're not tripping on each other. Because I think that one thing that we can do as an organization is make sure that our federal efforts are in alignment with what's really happening boots on the ground. And sometimes there's a disconnect there. So I think the Catalyst program has really been able to feed information from the states up to make sure that that alignment is there. And also our national partners are able to sort of coalesce around issues. And I think Colorado was one where ACSCAN and Fight Colorectal Cancer and state partners were able to really look at what was happening uniquely in Colorado and how can we come up with solutions. And maybe the solution isn't this year, but really looking at long-term efforts. Andy, is there anything else you'd like me to cover?
No, Angie, I think that does it. I really appreciate all the support for Fight CRC, and I think it's great to have our national partners around the table. So thank you so much.
No problem. Nice to be here.
Great. Okay, so we'll just do a few slides and then we're going to definitely transition to our partners and experts talking about the colorectal lung hereditary breast and cervical work. And then, of course, hearing further about our state cancer plan, the cancer control program, as well as really thinking about the equity initiatives from our teams at CDPHE, as well as American Cancer Society. And as noted, I'm going to hear some great feedback from Colorado Rural Health Center and CCHN about how this really fits within the larger fabric of our network and our CQI work moving ahead, as well as other initiatives. And then with our State Cancer Coalition and Christy Cahill as the leader, really talking about a return to screening campaign and returning to care, and how we're really trying to embrace that, which I think is really paramount based on coming out of the pandemic. So I'm going to move through a couple slides very quickly because we're just a little short on time. And then I will turn it over to Dr. Patel for today's lead out discussion around the latest and greatest in guidelines. So next slide. And next slide. Okay. So just as a quick reminder, when the CCSP program began almost 2006, 2007 back, we really were a direct screening program that offered navigation as well as direct services. With the expansion of ACA, the CCPD grants program, I think wisely, really devoted a lot of work for support and access. And so the navigation remained paramount in our program. And what I want to say is, as much as we really thought that direct services and providing money for colonoscopy for treatment were really the cornerstone of our work, that was true. But in parallel, navigation really did help elevate the work in terms of access to care and really increasing screening rates within the medically underserved and with our safety net partners. So as all of you know, the CCPD grants program has been the real support of our work, and navigation has been the name of the game and still remains the name of the game as we continue our work with all of you over since about 2014-15. Next slide. Our goals are still really about looking at, I think, as Angie mentioned, the national perspective of how are we doing in Colorado with an 80% in every community, thinking about health equity, health access, creating a healthier Colorado. And as we started with colorectal cancer as our foundation, we've definitely grown with partnerships as well as that navigation element through endoscopic screening being our primary mode. And since 2006 and inception of the program, we've now navigated over 30,000 people into colonoscopic screening. But we also know that number in terms of number of people we've provided access for stool-based testing, now moving into lung hereditary cancer work. That's probably well over hundreds of thousands of people with the amount of support and technical assistance. But for our program, the tracking of really that navigation into endoscopic screening has been really the core outcome. So we're making great gains, next slide, to be able to show ultimately the impact. And I want to just bring up this, and I think Dr. Patel might show some data as well, but really the cornerstone of also really the planning is really been thinking about the cancer incidence, mortality, the burden, and especially different regions in our state. So I really want to commend the state health department as well as the CHI teams who've provided some great input in terms of showing us what our screening rates look like, where we're seeing, later stage cancer, and then really looking at that economic impact in terms of the coverage for different things like insurance, and really thinking about income level for us to really think of program planning and where we're devoting resources. I think now more than ever, equity is really a part of the discussion, but we are one of the programs, as well as the WWDC and CPED program, that have been really in the business of thinking about equitable care for a number of well, actually for the last several decades. And so just want to remind everyone that we use a lot of data in terms of really thinking about our plan and approach. Next slide. And to that extent, knowing that 80% in every community has been a foundational component. We've seen really looking at the 2020 healthy people in every community, and really thinking about benching ourselves, but not just about Colorado as a whole, really think about the different populations that we serve. So much as we're looking at rural frontier, we're looking at specific communities and really looking at screening rates. We do break this down further into understanding where we're seeing deficits. So that skirted and dotted line is about that 70% mark, which is where we are overall in terms of Colorado's rate. We're a little behind that 80% where we'd like to be, but we are seeing some of the groups that are really starting to edge into that 70% and above, which is great. So Medicaid, insured, 70 to 75 population in terms of age groups, but really looking at rural frontier as well as uninsured, we have a lot of work to do. And that's why programs like CCSP and our partners are really critically important in terms of reaching those who have typically been considered medically underserved, and access is key to the work moving ahead. Next slide. So ultimately, again, that whole idea of since the inception of the program, even up to the last year, we are now showing over 30,000 people that have been diagnosed, or excuse me, that have been screened. We're seeing reductions in no-show rates, high preparation, BAL prep. People are showing up to the exam, completed exams, because we're really allowing quality navigation, funding that work, and really helping creating infrastructure. And then also really thinking about that barrier reduction. So these are the type of numbers that are really going to be critical for insurance providers, for others to understand, as well as funders to think about the impact moving ahead. So with the prevention early detection, we're also showing strong rates of cancers detected earlier stage diagnoses, less money, and improved quality of life in terms of treatment. So these are really the numbers, and this has really helped guide CDC's work around CRCCP, other states in terms of thinking about implementation and really thinking about a national approach to preventive screening. So I'm very proud of the work that you've all done in this field and really happy to be a part of this. It's also been, next slide, the foundation for the work that we're doing in terms of really branching out, moving ahead. So really, when we really think about the work we've done in preventive cancer screening and colorectal, as well as our partner program, the CPED and WWC, we have some proven strategies. And over the last 3 years, we've been really working hard on lung cancer screening implementation, which Dr. Dyer is going to speak more about approaches and how we're considering and the elements to consider. And then also looking at that family history and looking at genetic and familial-based cancers and how are we doing a better job of approaching that within primary care. So I'm excited that we've been able to use this type of foundation to think about integration, to think a little bit about a larger cancer preventive message, and something we'll definitely continue moving ahead. Next slide. And as I think we're thinking also about that whole idea of sustaining this work, we can't ignore the pandemic. We can't ignore what happened through 2020. And so ultimately moving in terms of looking at that reintroduction of preventive screening, that balance between risk as it relates to the virus, as well as what it means for prevention. These are things we're having to take into consideration. And we're very much monitoring the rates at which people return to care and screening based on the different parts of our state where access resides. So this is something, of course, can't be denied. And I know we've had conversations and what's going to be a part of our return to screening campaign. Next slide. But I think the good news is ultimately we have seen these sort of, we did see basically screening flatline for a period of time. but we are starting to see more return to normal type of approaches in terms of the rates of people coming back in. But we've seen that ebb and flow with flu and cold season, where we've seen, harsher kind of quarantine periods and that lift and the like. So these are areas that I think we're going to have to continue to really think about planning and how we talk to the patients, as well as help really provide support for navigators in the field to think about these approaches. Next slide. And I want to say just a word about sustainability. Ultimately, in our work through CCSP, as well as other partners in our planning, is that we know that we do have this 2-year extension, which we're going to talk a little bit about to continue the work. But sustaining the navigation role in preventive screening is going to be critical. And so we have some dedicated approaches in monies for us to really think through with our state planning partners, our federal partners, as well as our entities that work through our safety net clinic systems about how we're thinking about sustaining the role and function of navigation. So this has been a dedicated process. It's something we will continue. And we really integrated over the last couple of months our program partners in this work as well. So again, I think still when we're looking at that role of paying for navigation, it still is a bit elusive. But I will say that ultimately partners like Fight CRC, the National Navigation Roundtable, and others also have this as a priority area. So I think it's great that we're working at the state, local, and federal level to really think about navigation sustaining moving ahead. Next slide. And looking to the future. So essentially, again, we have that extension. So we are ending and sunsetting this grant cycle at the end of this June, starting fresh July 1. And this is really an opportunity for us to really engage and really look at that navigation sustaining moving ahead. But in this time, I want to give kudos to the CCPD program that we have shared that perspective, and Angie had mentioned this as well, that we know that there's probably going to be issues around capacity for structured exam like colonoscopy and the like. We are going to be doing more stool-based implementation, providing more support for population management as well as navigation. Ultimately, from what we've learned from the familial and risk-based care as well as lung cancer screening, we're going to look at stronger capacity building within all of our safety net clinic systems who are participating to think about next steps or maybe additional grant funding in future years, or how do we help really share that policy perspective about where we need to be going. And then ultimately, again, we're really going to be considering that sustainability and that function of navigation, and how do we help with that national and state voice around policy and implementation, and how do we help all of you build stronger policies internal to help support navigation as a mainstay, even beyond this additional 2 years of funding. And then I would just say integration has been key for us. I think Emily, Ivy, Chris have been really instrumental in thinking about how does CCSP as well as the breast and cervical program really function? How do we look at our thought partners in the other preventive sphere? And how do we really continue this work moving ahead? So this is really the name of the game. We'll be continuing to have startup calls with all of you after July to talk a little bit about these opportunities. Particularly for the funding for rollout for stronger stool-based testing implementation, as well as the capacity building. But I just want to say that I really appreciate this work. It's been fantastic. And I do think Colorado has remained a leader in this work, and very proud of the work we've done. So with that, I'm going to turn it over to Elsa, who's going to introduce our panel, and we will have Dr. Patel pull her slides up straight away. So thank you so much. If you have any thoughts, questions throughout the day, please feel free to use the chat. We will have some time for Q&A after today's panel, but Elsa, I'll hand it over to you.
And good morning, everyone. So nice to see so many people on. I'm Elsa Weltzine with the Colorado Cancer Screening Program, and now working with Fight Colorectal Cancer. We're thrilled to have a panel of 4 amazing leaders in the cancer prevention field in Colorado joining us today to discuss the latest and greatest information in cancer screening guidelines and the implications for cancer prevention and control efforts in Colorado, including for the CCSP program. So we'll be starting off with Dr. Swati Patel from the University of Colorado, who will be discussing the current colorectal cancer screening guidelines. And then that will be followed by Dr. Debbie Dyer, who will be focusing on the lung cancer screening guidelines. And then next, we'll have Melissa Gilstrap sharing about the current guidelines for hereditary cancer assessment. And we'll round out the panel with Emily Kinsella discussing the breast and cervical cancer screening guidelines and our state program, the Women's Wellness Connection. So Dr. Patel, I'll have you introduce yourself a little bit further. But just wanted to remind everyone that you'll have the opportunity for question and answer after the presentations, and we may be able to answer 1 or 2 questions in between each presenter. So I'd encourage you to put your questions in the chat as you think of them. So without further ado, I'll turn it over to Dr. Patel.
Great. Thank you. Elsa, can you see my slides okay? Give me a thumbs up if everything looks all right. You can hear me okay? Perfect. So good morning, everyone. It's really an honor to be here. Thank you for the invitation. This is such an incredibly important program and a perfectly timed program to talk about the updates in colorectal cancer screening in particular. And for years, I've been giving some version of what I'll be presenting today, but I am really, really proud to say that instead of this sort of being a question on my slide, it's now a statement. And so, of course, we'll be framing our discussion about colorectal cancer screening around the recent announcement by the United States Preventive Services Task Force. So what we'll do today is just spend a few moments talking about what we've been observing regarding what's happening around colorectal cancer nationwide. And then as Andy has kind of pointed out, some of the things that are relevant to our state. We'll review the colorectal cancer screening guidelines, in particular, the most recent updates that most are familiar with, and then talk about the screening options and some of the practical issues associated with screening and how we can guide our patients to promote screening in our communities. So we know that colon cancer is really a significant burden to our society. It's a leading cause of cancer incidence as well as cancer-related mortality, and really sits just behind breast, prostate, and lung. And really put another way, all of us have a 5% lifetime risk of developing colon cancer. So 1 in 20 Americans, if they don't undergo screening, may have to deal with colon cancer. Thankfully, in large part because of our successes in screening, we have seen a steady decrease in the incidence rates in all age groups over the age of 50 over the last several decades. And in large part, this is because screening really can take advantage of what we understand to be the biology of colon cancer. We know that most colon cancers essentially develop over a long period of time from small precancerous polyps that over time can grow and turn into cancer. And this dwell time can take anywhere between 10 and 15 years. And so the screening modalities that we have can essentially interrupt this process anywhere along this continuum. Unfortunately, as many are aware, over the last several decades, as we've seen rates decrease in those over the age of 50, we've unfortunately seen rates increase in all decades under the age of 50. And this was a really important paper published in 2017, where Rebecca Siegel published this data and really garnered a lot of public media attention to this issue, where many in our society were wondering and asking, why are young patients getting colon cancer? And of course, over the last few years, we thankfully have had continued attention to the issue, both from the scientific community and professional societies, but also as we see sort of tragic cases of high-profile individuals in our society succumb to this disease. And when we look at the incidence rates, in fact, the incidence rates for those between the ages of 45 and 49 now are identical to what we observed in 50-year-olds back in 1992 when we began starting screening. So the burden in these younger patients is currently the same as screen-eligible populations that we've historically offered colorectal cancer screening to. Andy showed us the statewide data and the heat map of where colon cancer is affecting our state the most. It's actually not surprising that although colon cancer rates in young patients is increasing nationwide, there is some geographic variation. The incidence rates similar to those observed in older patients are much higher in southern states, the Appalachian region. And what's really interesting when you start to think about how this applies to our state is that it's probably not as macroscopic of an observation as state by state trends, because this recent paper published showed that the incidence rates have actually been climbing faster in rural counties compared to urban locations. So when we take all of this at stake and we look at these curves where the rates in those between the ages of 20 and 49 are increasing, the rates in our older populations, thankfully, in large part due to screening, are decreasing, one sort of may pose the question of, well, what do we do about this? And even before we talk about what we do about this, maybe a cynic might even ask, well, should we do anything about this? And those cynics call your attention to the y-axis here, where you look at the incidence rates and mortality rates in absolute terms. And of course, you can see that there's been an increasing trend, but for 20 to 49-year-olds, we're talking about an increase in incidence rate of approximately 10 to maybe 13 or 14 out of 100,000. Whereas even though the rates are decreasing in older populations, we're talking about in the order of hundreds to 400s of individuals per 100,000. So the magnitude of risk is still quite a bit lower in younger patients, although the trend has been going in the wrong direction. And putting these side by side, these curves for those under the age of 50 are quite a bit different in terms of absolute risk compared to what we're seeing in our older populations. But I might say that the impact of this disease in younger patients really far dwarfs and puts into perspective these curves. This is a demonstration of really person years of life lost due to colon cancer diagnoses stratified by age. And if you look at diagnoses in those 45 to 49, essentially the person years of life lost almost is equivalent to colon cancer diagnoses for individuals between the ages of 65 and 69. And this really is of no surprise. Younger patients are incredible contributors to our society, not only economically in the job force, but of course are caretakers for younger family members, oftentimes older family members. And the impact of a colorectal cancer diagnosis in a younger patient really has broad implications, and the financial toxicity associated with this is quite significant. And so I would argue, and I think all of our professional societies now essentially are coming to agreement that we absolutely must do something about this trend that we're observing. So in 2018, the American Cancer Society responded to these trends by essentially recommending on a qualified basis that really we should be considering average risk colon cancer screening starting at the age of 45. And so this really is for individuals without family history, without symptoms, but just the average population. And they kind of persisted with their strong recommendation that it certainly needs to be done in patients 50 and older, but was the first society out front to really say we need to address this issue of early age onset colon cancer. So why didn't kind of widespread practice change? Well, in part, this is because of a lot of the barriers that we deal with in even the older population, and that is access and insurance coverage. And so this is not completely updated, but essentially the blue states highlighted here are states that do recognize the American Cancer Society guidelines in coverage, whereas states in gray are either in the process of trying to fight that or really do not cover American Cancer Society recommendations. But of course, as we all know, under the Affordable Care Act, must recognize the United States Preventive Services Task Force guidelines. And so that's really why the news this past week has been so monumental for improving screening in younger patients. And so in October of 2020, the USPSTF essentially put out their draft of their recommendation to say that really in the kind of thorough evidence review that they had done, which is a combination of clinical studies as well as their microsimulation models, that the USPSTF was considering decreasing the screening age for average risk individuals to 45. This, of course, was open for comment over the last few months. And then this past Tuesday essentially became official that indeed the United States Preventive Services Task Force now recommends starting average risk colorectal cancer screening at the age of 45. We all are familiar with the grade recommendations associated with USPSTF recommendations. And so based on the strength of evidence, they still recommend starting screening at age 50 as a grade A recommendation, and acknowledging the gaps and limits in the data that we have, recommend the USPSTF guidelines to start at 45 as a grade B recommendation. This is still critically important because under the Affordable Care Act, any grade A or grade B recommendation does not allow cost sharing with the patient. And so this means that individuals can access these screening services without co-payments, without needing co-insurance, or without this going towards their deductibles. This is really transformative for access when the USPSTF finalized this on Tuesday. So what about the other professional societies? Well, we know about the American Cancer Society, which was the first out of the gate back in 2018, the USPSTF this year. In terms of our GI societies, the American College of Gastroenterology also came out with a recommendation to suggest screening in 45 to 49-year-olds. The National Comprehensive Cancer Network in 2021 also said that screening can be considered on an individualized basis between the ages of 45 to 49 as the first exam. And the Multi-Society Task Force, which is essentially a collection of our GI societies, the American Gastroenterological Association, the American Society for Gastrointestinal Endoscopy, and the American College of Gastroenterology, are actually currently actively revising their guidelines and are expected to be in line with starting screening at age 45. So what are the screening options? Well, there's a whole menu of options. And we talked about what the guidelines recommend for when to start. The USPSTF essentially recommends a panel of potential options for our patients. And though we don't have enough time to really dive into the details of all of these options, I think it's important to contextualize what these different types of tests are actually designed to do. And so the most common tests that we use are either stool-based tests, as Andy mentioned, so fecal immunochemical testing, FIT, fecal DNA, which we all are marketed to if you tune into NPR or the evening news, and then structural tests, the most common of which is colonoscopy. But these tests are designed to do different things. And I think that's important when we think about our discussions with patients about what they expect to gain from colorectal cancer screening. So we talked about our understanding of how colon cancer develops. When we think about structural tests, such as colonoscopy, structural tests can essentially detect lesions anywhere along this continuum. So of course, it's a cancer screening test that can identify colon cancers, ideally before a patient has symptoms, ideally at early curable stages. But it's also a cancer prevention test because it can detect these precancerous colon polyps, remove them, essentially interrupt the natural history to colon cancer development. On the other hand, stool-based tests, such as fecal immunochemical testing, FIT, stool DNA, are kind of traditional cancer screening tests. And so those are tests that rely on any material that a tumor might shed into the stool. And the sole kind of primary goal of a stool-based test is early detection of cancer before a patient develops symptoms. And so this is just important to keep in mind as we talk to patients about colon cancer screening options, because yes, all of these tests screen for colon cancer and are effective in detecting cancer early, but there's a distinction between cancer screening versus cancer prevention as well. And we won't spend much time on the blood test that's available. Though it's FDA approved, it's really not recommended by any of our professional societies because of poor sensitivity, less than 50% or so in detection of colon cancer. But that's even on the furthest end of the cancer spectrum, where it really only detects cancers that are now kind of seeping abnormalities into the blood. What's really important to understand about all of these tests outside of colonoscopy is that they're considered two-step screening tests. And so Andy talked about the importance of navigation for patients who have, for instance, a positive fecal immunochemical testing and getting them to a high-quality colonoscopy. But really any one of these screening options, if there's an abnormality identified, require a colonoscopy to actually identify what exactly that abnormality is, get tissue samples or biopsies, and essentially allow further care for that patient. So we'll spend just a few moments talking about the most common colorectal cancer screening tests done in the United States, as well as the state of Colorado. So these stool-based tests, as well as colonoscopy. So the stool-based tests really, as we talked about, are two-step tests, and they essentially rely on the concept that a tumor within the colon can shed material into the stool that our testing can then pick up as a potential screen for cancer. The oldest iteration was the traditional fecal occult blood testing. And this had quite a bit of limitations. It wasn't specific to human blood, and it wasn't specific to any specific location in the GI tract. And so it was quite cumbersome. We would have to ask patients to avoid meats because we didn't want to pick up any hemoglobin from the poultry they were eating or the steak they had. We had to ask patients to get 3 successive smears to improve the sensitivity. And we really wouldn't be able to tell whether it was hemoglobin from maybe a stomach ulcer, stomach irritation, or a colon source. So we tried to mitigate those things by asking patients to avoid medicines that could sometimes cause GI irritation, but it really wasn't an ideal at-home screening test because of these limitations. Thankfully, the kind of most recent iterations of this test is the fecal immunochemical test, which is specific to human globin, doesn't require any restrictions in terms of diet or medications, and really has good sensitivity with just a single sample. And so quite a bit easier for our patients to comply with. And the concept really is that if there's a tumor within the colon, it may be ulcerated, may be inflamed, it might shed microscopic blood before it actually causes symptoms, and that these tests can pick that up. But of course, blood can happen for a lot of different reasons, whether it's from a colon tumor versus other benign things like a little irritation or hemorrhoids or maybe even a spicy Indian meal the night before. And so it's not specific to colon cancer, but is a good kind of first line screening test that then requires a follow-up colonoscopy to find out why that was positive. The newest iteration of stool-based testing that we use is FIT DNA. And so this test is actually a combination of FIT and then DNA markers that can be picked up through this stool-based test that can be associated with abnormal mucosa, potentially cancerous, potentially precancerous changes. And so how do these tests actually perform? Well, it's no surprise that as we go through the generations of these stool-based tests, the sensitivity for picking up cancer improves, but it's not 100%. So if you have 10 patients with a confirmed colon cancer, the stool DNA plus FIT will pick up about 9 out of 10 of those individuals. FIT will pick up about 8 out of 10 of those individuals. But again, this is a test for cancer screening, not pre-cancer screening or cancer prevention. You can see that the sensitivity for precancer polyps or adenomas is less than 50% for the most part across the board. We're all familiar with sort of the differential in cost associated with these tests. And as we kind of think about these things, one of the most important things to understand is, well, we can understand the sensitivity for picking this up for patients with confirmed colon cancer, but does this testing as a program for the state of Colorado, for large health networks, actually impact the outcomes of interest? Does it decrease death from colon cancer? There have thankfully been really large clinical trials, including hundreds of thousands of patients, that essentially consistently have shown a significant reduction in colorectal cancer associated mortality. So it is an effective test at screening and finding cancers before patients develop symptoms, as long as they get that follow-up colonoscopy to actually sort out what's going on, and as a program can decrease the burden of colon cancer associated death in our society. So quite a few advantages. It's of course low risk, non-invasive, doesn't require that purgative bowel prep, can be done in the home, and it's inexpensive, at least for the fecal immunochemical testing option. But again, it just needs to be acknowledged that's not a cancer prevention test necessarily. It does require annual testing. And of course, it's not specific for colon cancer. And so it does require that follow-up colonoscopy to understand why that test was positive. Colonoscopy, we're all familiar with. Of course, the kind of biggest and most important issues around this is being well prepared for the procedure and being able to actually get to the procedure. And the issues around access and cost. And so we know that the colonoscopy to be effective requires a good quality bowel preparation that requires patients to stay on clear liquids the day before the procedure and do a purgative bowel prep the evening before and the morning of the procedure. But the advantage is that we can essentially visualize the entirety of the colon, remove polyps that we see, sample any abnormalities such as tumors while we're there. So it's a single step test. And it's a cancer prevention test that, we can find these adenomas and remove them before they turn into cancer. However, it's disruptive and it's costly, and there are barriers to completing a colonoscopy. The standard of care for the most part is to provide sedation for the procedure, though it's not absolutely required for all patients. And it requires patients to take a day off of life, family, work, all of the obligations and responsibilities they have. And because a sedative is oftentimes administered, requires a family member or a friend or a community member to bring them to the procedure. And it's really, really makes me so proud and happy to hear about Andy present the numbers on bowel preparation quality, because the quality of the exam very much hinges on the quality of the bowel preparation. When we do colonoscopy, grade this prep, as you can see, and you might wonder, well, gosh, for the polyp that I envision, even in that poor prep situation, it seems like it would be very hard to miss this large protruding polyp. But in fact, many of the polyps that we see don't look this obvious and can be these flat polyps that we see throughout the colon, and very easily can get obscured even in patients who have a fair prep. And so the quality of the bowel prep is critically important. And the reality is both of these polyps are just as precancerous as the other. Does colonoscopy work for the outcomes that we're interested in? Does it decrease colon cancer associated mortality or rates of colon cancer? Well, there's really not any prospective randomized controlled trials published to date, but it's not really because it's not effective. It's just that they're still ongoing. We have a lot of indirect data that colonoscopy is highly effective. The National Polyp Study showed an up to 90% reduction in colon cancer incidence. A large VA study showed that those who had had a colonoscopy in the past 6 years had a 60% reduction in colon cancer associated mortality. And then of course, all of these trials, the FOBT trials that I showed you, the FLEX-SIG trials that I haven't showed you, that have shown decrease in colon cancer mortality, that had to happen because of that follow-up colonoscopy. A stool test alone in isolation would not impact these clinical outcomes. And we certainly will have data on the efficacy of colonoscopy as well as how it performs in comparison to stool-based tests. So the VA is conducting a very large clinical trial randomizing patients to colonoscopy versus FIT, completed recruitment in 2019. So we'll have the 10-year mortality data this decade. And there's a similar Spanish trial that's underway, and then a Nordic trial looking at colonoscopy versus no screening. So to summarize, there's certainly advantages to colonoscopy. We can visualize the entire colon. We can diagnose lesions, remove them while we're there. It's a one-step test. It only needs to be done every 10 years if we get a very good look in terms of the bowel prep and we don't find any polyps. And with sedation, oftentimes minimal patient discomfort, and it's a single step test that doesn't require that second follow-up. Of course, the disadvantages and the barriers that a lot of our patients cite and face are that it's invasive. There can be some risks associated with the procedure. It requires sedatives, can be time consuming, and requires that full bowel prep. So what about the risks? I'm the first to say, as someone who does colonoscopy all day, every day, that it's not a procedure without risk, and I certainly wouldn't dismiss it to a patient. The main risks that we tell patients about are that we could cause a hole or a tear through and through the wall of the colon, There could be bleeding risk, oftentimes associated with polyp removal. And although extremely rare, there is the possible risk of death. And these are all very real, very scary risks. However, to place them in a little bit of context, if all of these dots are individuals undergoing colonoscopy, this is the proportion of individuals who would have a bleeding issue. This is the proportion of individuals who would have a perforation. This is the proportion of individuals who might die. And yet, a much larger proportion of individuals, unfortunately, would be affected by colon cancer if they didn't have a screening test. So our patients oftentimes ask us, and I'm sure they ask you, okay, well, the USPSTF sort of supports this menu of stool-based or structural tests. Which one's the best one? Well, I think it's important to keep in mind the screening rates, some of which Andy really nicely demonstrated based on Colorado data and different subgroups. But in general, really a significant proportion of Americans, even 50 and up, putting aside the 45 update, are actually screened. And in the state of Colorado, as of 2016, that rate was less than 70%. And certainly certain subgroups are doing a little bit better than others, but we have much work to do. And when we look at the screening rates by age, those 50 to 54 are right around 50%. And so we have this new expansion of screening in 45 to 49-year-olds, but it really shouldn't distract us from continued efforts at getting our older patients screened. There's a lot of barriers that we've talked about. The menu of options are certainly there, but the critical importance of navigating patients from two-step tests from that first step to completion of screening with that second step. Continued legislative efforts to ensure that the entirety of screening is covered without cost sharing to the patient. A colonoscopy can certainly be done safely, but also ensuring that it's done in partnership with endoscopists who prioritize modesty and cultural sensitivity for particular patient subgroups, and continued education and engagement with patients to optimize bowel prep. And then, of course, all of the unique challenges that our patients face in getting to colonoscopy. And so creativity with assisting with rides. And so certainly many things that we can improve upon. So if I leave you with a few final thoughts, we all know that colon cancer is common, it's lethal. We are seeing increasing rates in younger patients, which demands our attention, which I think our professional societies are providing that spotlight and attention to, but it doesn't detract from our efforts in those over the age of 40. And we know that colorectal cancer screening is highly effective and it saves lives. And the best test is the test that can get done in totality. Whether it's a two-step test, the entire screening process needs to be completed. So thank you very much for your attention. Happy to take questions through the chat box and then join the Q&A at the end of the session.
Thank you so much, Dr. Patel, for that great overview. We did have one question come through, and while we go through that question, Debbie, if you want to bring up your slides so we'll be ready to transition to lung cancer screening, that would be great. But Dr. Patel, so there's been discussion that moving the guideline to 45 could create deeper equity issues. So I was wondering what you would say about how CCSP and other partners doing cancer screening, particularly colorectal cancer screening work in Colorado, can help ensure that people of all ages are getting screened, and some of those populations that have traditionally seen more disparities in screening rates don't get left behind.
That's an incredibly important point. As we expand screening, it has to be in a thoughtful way such that we educate and engage with communities that are really underserved, even as we think about colorectal cancer screening in older age groups. And so I think, one of the greatest strengths of the Colorado Cancer Screening Program is that there's a great track record for not only identifying and doing sort of the needs assessment in terms of data collection, some of which Andy really presented in identifying exactly the subgroups, the geographic locations, the different demographic subgroups that have lower screening rates, but then using that data to essentially extrapolate to our 45 to 49-year-olds, because those will oftentimes be the similar populations that will be at risk for potentially being left behind. But I think one of the big messages that we're working with, at least our academic partners, is to emphasize that there really is a kind of spectrum of screening options that we would like to offer our patients. And for the patients who, really aren't able to get, for instance, colonoscopy, stool-based screening is highly effective. We know it decreases mortality associated with colon cancer. And so I think, broad education about the spectrum of options and engagement with the typically underserved communities, the way that CCSP has been doing, will continue to be very important. And I believe that just bringing this issue to attention will in fact improve screening rates in that 50 to 54-year-old age group where we see a lot of deficits. And so very, very important point, and something we have to be proactive about, because passively just putting these recommendations out there, won't necessarily address the disparities. There needs to be, specific dedicated programs. And I know University, Denver Health are working on a lot of those initiatives in part, in partnership with CCSP.
Thank you so much. Yeah, really important points. And thank you so much to all of our health navigators who are really working one-on-one with those patients and making sure they have all of the information they need to make informed decisions. So I'm going to transition over to Dr. Debbie Dyer from National Jewish Health, who will be giving us an update on the current lung cancer screening guidelines and efforts in Colorado. So Dr. Dyer, please go ahead, and we can see your slides just great.
All right, great. Yes, so I'm a cardiothoracic radiologist. I work at National Jewish Health in Denver. I also chair the American College of Radiology Lung Cancer Screening Steering Committee. And I'm going to be going over the new U.S. Preventive Services Task Force guidelines. I'm going to describe a little bit about the reporting system that we use and discuss some about the barriers to lung cancer screening. So this was the good news for us in lung cancer screening on March 9th. The U.S. Preventive Services Task Force did update and provide their final recommendation for lung cancer screening, CT. They dropped the age to 50 for starting screening and the required smoking history of 20 pack years instead of 30. This was given a grade B recommendation, and the schema that they basically are recommending is something that they call the 50-80-20-15. So they've, as I mentioned, they dropped the starting age to 50. They dropped the pack year history to 20. They kept an upper age limit of 80. And then they kept in place that either patients have to have quit smoking within the past 15 years or be a current smoker. And the change in the age and pack years will help address the disparities in lung cancer screening. The data analysis that the task force did shows that they expect an increase in the percentage of eligible patients to be about 87%. And that is a particular increase among Black Americans and Hispanics. Other recommendations that these guidelines indicated was to continue screening on an annual basis. They recommended using the age and smoking history to determine eligibility rather than some of the more elaborate risk prediction models. Some of you may be aware of the Tamamagi criteria. There's the Mayo Clinic criteria. Those are more complicated. In some studies, they've definitely been shown to be more predictive of lung cancer. But the truth is they do take some time, and as lung cancer screenings are already pretty complex. So the task force felt it was important to keep the age and smoking history as the major determinants for eligibility. They do recommend that all current smokers enrolled in lung cancer screening receive smoking cessation interventions. They consider shared decision-making to be important. And they did comment that the lung RADS reporting system that we're currently using is helpful in determining which nodules are suspicious and can decrease the false positive rate. So their assessment of the net benefit was they had moderate certainty that annual screening for lung cancer with low dose CT has a moderate net benefit. And that is the definition for the grade B. You know, you noticed with colon cancer screening, there was a grade A. Well, what do you have to have for a grade A? It does have to be that there is high certainty that there's a substantial net benefit. So the data we think is very strong in lung cancer screening, but the task force decided to continue with the grade B. Now, the timeline for implementing these new eligibility criteria is going to be complicated. Because of the Affordable Care Act, commercial insurance, and state Medicaid expansion plans, so Colorado is an expansion state, most will have, well, they do have up to 1 year after the new next contract year to implement these new criteria. So unfortunately, that means that they're not absolutely required to do this until January 2023. Payers can, however, voluntarily cover these eligible patients sooner. And we did just get some good news yesterday that Aetna nationally has indicated that they have updated their guidelines, and Aetna should be covering patients with these new criteria. I haven't seen it myself, but I did receive an email yesterday about that. Of course, the other major group that does need to change their eligibility criteria is Medicare. Medicare is not obligated to use the task force recommendations, but this did certainly prompt Medicare to reopen their national coverage decision. And as of just 2 days ago, they did put up on their website that we are now in the 30-day comment period. And so they're asking for input on what their new decision should look like and what their criteria should be for coverage. And so everybody needs to get their comments in by June 17th. The bottom line, though, is that this whole process of commercial and Medicaid and Medicare coverage could take many months and really up to about 2 years. What's troubling about that is that puts all of our navigators, all of the program coordinators, all the facilities that are offering screening, the patients and the providers are just in limbo. I mean, you just don't know. A provider could say, all right, I would, my patient's 50 and has 20 pack years, I'm going to refer him for screening. And we just don't know until we really check if perhaps one of their, if their insurance is more one of the progressive ones. So it's going to be a bit of a transition period. The other good news, though, that has happened for lung cancer screening in just the past couple months is that as of March 31st, the American Academy of Family Practice updated their recommendation. And prior to March 31st, the AAFP considered there to be insufficient evidence for them to recommend lung cancer screening. After they reviewed the task force recommendation, the AAFP did actually then change their recommendation now to a grade B. And obviously we expect a lot of the referrals from lung cancer screening to come from the primary care community. And so having this recommendation now from the AAFP is going to be a very valuable asset. So where are we nationally in lung cancer screening? Well, one of the criteria for Medicare to cover lung cancer screening was that every case had to be entered into the national registry. I will admit that the data in the national registry is incomplete, but this is what we have so far. The American College of Radiology is the only CMS approved registry at this time. So I'm presenting you here the data from the American College of Radiology registry. So you can see the coverage, Medicare coverage started in 2015. And so from 2016 to 2019, there was definite growth nationally in the patients receiving this is baseline lung cancer screens or annuals. And then of course things fell off a bit in 2020, but we have made great efforts to resume screening and make patients feel safe and provide safe environments. So I do expect that our numbers in 2020 are going to again show growth. So what are the necessary components for lung cancer screening? I mentioned earlier that it is complex. There does have to be sort of pre-screening for screening to see if the patient is really eligible for screening. Most programs have a navigator that does this. There does have to be an order for lung cancer screening, and the ordering process has to document eligibility, completion of the shared decision-making visit, and a pre-auth when it's required. The CT technologists have to be trained to do low-dose CT, and the facility has to have a specific protocol for low-dose CT, and preferably separate protocols for small, medium, and large patients. Radiologists reading these exams have to be trained in lung rads. Facilities need to have some sort of a tracking system to monitor and remind patients of necessary follow-up and annual exams. And facilities have to submit demographic data and exam data and results to this ACR lung cancer screening registry. There are up to 62 different data elements that could be submitted for each patient to the registry. So that is a burden. There is also a requirement that patients who enroll in lung cancer screening, if they're current smokers, that they be offered smoking cessation interventions. So best practices overall in general, I'll just highlight a few of these here. It is important to recognize that lung cancer screening is a program, it's a team effort, it's not just a CT. A navigator is a must. Programs do have to have a method of communicating the results to patients with a patient-friendly letter. There does have to be some sort of IT infrastructure or software to track patients and then submit the data to the ACR registry. It is very important that some sort of a multidisciplinary nodule conference or nodule clinic be established so that the suspicious nodules can be reviewed. And then, as I mentioned, the smoking cessation services are important. And the other thing we see are incidental findings. So, of course, we're seeing the chest, so we can see other things. We can see the aorta and the coronary arteries and the thyroid. And so there does have to be a system for managing those. This is pretty much a review of the team of people that need to be involved in lung cancer screening. And then, as I mentioned, LungRADS is the reporting system we use. It was initially adopted in 2014 and updated in 2019. It defines a negative versus positive exam. It provides consistent guidelines for follow-up, and there is an S category for identifying significant incidental findings. And this is what it looks like. And just to give you sort of a highlight of the most concerning nodules are those that are called either a LungRADS 4A, 4B, or 4X. And you can see here in this highlighted area of that LungRADS schema that our recommendation here is based on what the nodules look like, whether they're solid or part solid. And then the recommendation would be maybe a 3-month follow-up then if it's the category 4A and it's a nodule that is 8 to 15 millimeters or growing. It is determined that about 5 to 15% of these patients will have a malignancy. A very suspicious nodule is the 4B category. These are the ones greater than 15 millimeters. They're growing quicker. If they're part solid, they have a growing solid component. These are the ones that need immediate attention, typically with a PET CT or a biopsy, as it's thought that about greater than 15% of these patients will have a malignancy. And this is just an example of how it works. This was a LungRADS 4A lesion. It was part solid. We're looking at the left lower lobe of a lung. And so we've got this ground glass area and then this solid nodule here. This is up against the chest wall. It was recommended the patient come back in 3 months, and they did. And now you can see how that nodule has grown, the solid part in particular. It is very irregularly marginated. So at this point now, the patient gets a biopsy. It's determined that it is an adenocarcinoma, and the patient gets a wedge resection. They don't need a full lobectomy. And this was a stage 1 lung cancer, and this is considered a cure. So this is actually what we're striving for. I mentioned a little bit about the S findings. So the most common one we see is coronary artery calcification. After all, these patients are smokers. They're more likely to have coronary disease. But we also can see interstitial lung disease, aortic aneurysm, lymphadenopathy, and masses in the thyroid or breast. We also see the top of the kidney, and we certainly do pick up renal cancers. Now, as far as enhancing our patient communication, I think one of the things we do in our program, but any program should send at least a patient-friendly letter with a summary of the CT results. In our program, we attach a copy of the CT report. Our navigators also call the patient to make sure they receive the letter and see if they have any questions. In our program, we have nurse practitioners meet with every patient ahead of time to do the shared decision-making, and they offer every patient a follow-up visit to review the CT results. And fortunately, this can now be done through telehealth. If a patient has a LungRADS 1 or 2, so it's considered a negative exam now, we can go ahead and schedule next year's. If the patient needs further workup, if it's a LungRADS 3 or 4, it is important that the patient understand at that point that the follow-up imaging or procedure is now a diagnostic exam and that there will likely be a copay. I did mention a little bit about the Multidisciplinary Suspicious Nodule Conference. I think it is very important to offer this conference. You can tag it onto your lung tumor board, review the more concerning cases, these LUNGRADS 4 cases each week. And then it's very important to invite the referring providers. They can call in because many of these conferences are now on Zoom. And then afterwards, just to be sure to close the loop and make sure the referring provider knows what the conference recommendation was. I mentioned that certainly we have barriers to lung cancer screening. You know, you all are talking in the colon cancer world that, you know, 70–80% of your eligible patients are getting screened. In our world, only about 4 to 5% of patients are getting screened, maybe up to 12% in some states. But we're not, you know, as experienced, and we haven't been around as long as colon cancer screening, but we do know that it's a lot of what makes lung cancer screening so difficult are the barriers. We have patient and provider lack of awareness. There's certainly the guilt and stigma about smoking. There's the complex eligibility requirements, and it's difficult to sometimes identify who is eligible. There is the requirement for shared decision making. And I will say that one of the things that many people are considering now that we have this opportunity to provide comments back to Medicare, they are the ones that initiated the requirement for shared decision making visit before lung cancer screening can be done. And some folks are going to be asking that Medicare be less restrictive about that. Certainly shared decision making is important, but the extent of elements that need to be covered in the shared decision making does make it a burden. There is the concern about providers knowing how to manage findings, and then also there's the data entry into the ACR registry. Some of the financial barriers are that there's relatively low reimbursement for lung cancer screening CT, and there is no compensation for the added tasks of submitting the data to the registry and tracking all these patients and doing any of the nodule conference work. So the challenge is only about 4 to 12% of eligible patients are getting screened. Currently, there's about 9 million Americans eligible. With the new U.S. Preventative Services Task Force eligibility recommendations dropping the age to 50 and 20 pack years, it's probably going to double the number of eligible patients, which is good news, but we've got a lot of work to do. So I think I'll stop there, and I'm happy to take questions.
Thanks so much, Debbie, for setting the stage for lung cancer screening and that great overview for some people on the call who might not know the guidelines as well as they do for for colon cancer screening. So one question we had is, if you had to give advice to clinics who are just starting to think about doing lung cancer screening work, especially for those primary care clinics, could you give a little bit of an overview of how clinics might start out and what they might need to consider? And as you're answering that, I'll have you stop sharing your screen so we can have Melissa bring up her slides.
Yes, so I think if you're just going to be starting lung cancer screening, the most important creature is your navigator or program coordinator. And this is the person that is going to help look at whether you have an EMR that may be able to identify potentially eligible patients, or if it's just some other sort of chart review or search that your clinic can do. I think the navigator is very important in initially identifying who might be eligible patients, and then they are the key person that reaches out to the patients to get them in for their visit, for the shared decision-making visit with a provider, and then to get the CT scheduled. So I think the initial really, really valuable person is the navigator. And you know, if you're just starting out, you may have a navigator who also works on colon cancer screening. So you might be able to share them or buy a little of their time. And, you know, it's sometimes a slow ramp up, but that's okay. Even if you can start out and get some folks engaged, you can work out the kinks. And I think just remembering that you have a team concept of you need to partner with a place, a radiology facility that can do the CTs. You need to make sure your primary care community is on board. And then you do have to have the team of experts, the pulmonologists and the oncologists and the surgeons engaged, so that they are the ones that, you know, are going to be doing more of the higher level workup if necessary.
Thanks so much, Debbie. If anyone else has additional questions for Dr. Dyer, I'd encourage you to put them in the chat, and we can make sure to address them in there. So I'll now turn it over to Melissa Gilstrap, who's a certified genetic counselor with Centura Health, who will be talking about hereditary cancer risk assessment.
Perfect. Thank you so much. And can everybody see my slides okay?
Yes.
Wonderful. So yes, I'm a genetic counselor based at Parker Adventist Hospital, mainly seeing individuals for cancer risk assessment and hereditary cancer genetic testing. I also run a young survivors support group for individuals diagnosed in their 20s and 30s, and this is a shameless plug for that. If you have patients who are in that age group, please send them our way so they can have an avenue of connection. And personally, I'm a Kansas City native who loves all things Colorado, and those are my people. So today I'm going to give a very quick and high-level overview of some of the really exciting things in genetic testing and genetic counseling right now, and show hopefully the impact of what getting genetic counseling referrals into your clinic can really look like. So just as a reminder, when we're talking about hereditary cancer, we're talking about individuals who have an inherited genetic mutation that came from either their father's side of the family or their mother's side of the family. Most commonly, they can be new mutations as well. And that mutation puts individuals at increased risk for cancer. We also care about the familial risk, which we think of as small genetic factors adding up with lifestyle and shared environment. And that's something that there's been a lot of growth in as well. Many of our genetic tests actually have single nucleotide polymorphisms that are now used to give a risk score or an estimate of certain cancer risk, even if an individual tests negative. So we're starting to be better at really fine-tuning not only the hereditary risk, but that familial risk. You hear the buzzword of personalized medicine all the time in healthcare. And this really is personalized medicine in action. It helps tell us who needs what, surveillance and treatment. So this would be an old example. This was exactly what I used when I was first a young genetic counselor in 2009. When we talked about hereditary breast cancer, we talked about having BRCA1 and BRCA2, probably some other rare genes, but a big portion that was unknown. And now today we are able to test with next generation sequencing all of these different genes. While BRCA1 and 2 are still really big players, there are many other genes, and each cancer type has similar flowers there where you can see all the different genes that are involved. And what's been really exciting over the last 5 years is we're not just trying to pick the right gene and hope we're testing the right one. We can do testing that has all of these genes in one test at one time. And it's really revolutionized what we're able to find for individuals and get the right care and the right screening to the right people in the family. just as a very quick patient example, this is a situation I see all the time where an individual is having some irregular bleeding. Her physicians are considering, should we do oral contraceptives, consider an ablation, or potentially a hysterectomy? But thankfully, this Sarah has some really good primary care or OBGYN physicians who say, you know what, you have a family history that we need to consider. With breast and ovarian cancer in the family, as well as colon cancer, we need genetic testing in order to provide you the right care. So her physicians recommend genetic counseling and genetic testing prior to deciding what they should do for her. And in this example, which is a very common one in my clinic, we find a couple of mutations. We find a BRCA mutation that leads to an increased risk for breast and ovarian cancer, but also a relatively common MUTYH mutation that leads to a slight increased risk for colon cancer. So I'll go back here so you can see those cancer risks. By doing that genetic testing, we have gone from giving general population risk estimates to Sarah to now significantly elevated risk estimates so that she can now get personalized care. She decides to have her ovaries and uterus removed as her treatment for the abnormal bleeding. And this is a very important factor. Instead of her physicians trying multiple oral contraceptives or maybe an ablation, because of her genetic test results, this fast forwarded her to now going to the hysterectomy. She also decides to meet with a breast surgeon to get the appropriate breast screening or prevention, and has a colonoscopy a little early and finds those polyps that can be removed, thus preventing a cancer. One thing I want to bring up is it's not just important to receive genetic counseling and testing if your family has a mutation in it. Negative genetic test results and those patients who test negative still can receive really valuable information from genetic counselors, because we do risk estimates for their cancer, lifetime risk for breast cancer. And we also make personalized screening recommendations, whether we find a mutation or not. So if an individual is calculated out to have an increased breast cancer risk, they may qualify for earlier mammograms. They may qualify for whole breast MRI or whole breast ultrasound screening. And again, we often do those earlier than what is typical if there's an early breast cancer in the family. Colon cancer, same thing. We might start more frequent colonoscopies. And these are individuals who we might suggest, because of your family history, instead of utilizing the other colon cancer screening techniques, we really would recommend a colonoscopy. So we can help tailor those recommendations there as well. A lot of individuals give us calls, and us being genetic counselors saying, okay, how do I know who should be coming to see you? And in reality, these guidelines are changing all the time. The National Comprehensive Cancer Network is the best place to find these guidelines, but they are updated 1 to 2 times a year. I would suggest that anyone who is involved with these types of referrals to create a free login on nccn.org and to view these guidelines regularly, and especially if you have a patient with a family history of cancer, so you can make sure you're referring the appropriate people. Big changes, I would say, to these guidelines to keep in mind would be that anyone with metastatic breast cancer qualifies for genetic testing and counseling, metastatic prostate cancer, and a big one is pancreatic cancer at any age. This is something that at Centura, we are really following this, because in 2020, only about 1/3 of these individuals were referred. What we hear sometimes is that, well, they have lots of different care and things going on at the beginning of the diagnosis. So we really just wanted to push that off for a little bit. And what we are really trying to get out there is that pancreatic cancer by nature, unfortunately, often by the time individuals would receive those referrals, they are in end of life care, or they have already passed away. So we really want to push for genetic counseling being considered part of the initial workup for a hereditary for a pancreatic cancer diagnosis. especially since there are also targeted therapies in some cases for individuals who test positive. So it's not just about getting the family the appropriate information. It can also be about making sure that the patient is receiving the appropriate treatment. And definitely get to know your neighborhood genetic counselors. If you have questions about if people would be appropriate for screening, be appropriate for genetic testing, reach out. We are always happy to have those conversations about what a patient's family history looks like, what diagnoses they've had themselves. We want to make sure the right people are getting referred. So always feel free to reach out. And a big thing in our world right now is many clinics have about a 3 to 6 month wait for non-urgent referrals, but we do see urgent referrals right away. I hear often that, well, that's just such a long time for patients to have to wait. And I say, yes, absolutely it is, but still refer. While we're working on getting more genetic counselors and more appointment slots, get them on our wait list, get them in our clinics so that we can still make sure people are getting the right screening and prevention. There's also a really important act that has actually been presented to the Senate and House very recently that would allow Medicare to consider genetic counselors providers, and it would definitely reduce a major barrier to genetic counseling for Medicare patients. At Centura, our Medicare patients are self-paying for our appointments, which means that many of them actually cancel and decide not to receive the services that they technically qualify for. So we're hoping that this will get passed. And if anyone has any desire to reach out to their members of Congress, that would be great to support that bill. And then telehealth. One of the big surprises of 2020, and one of the good things about 2020 is that we really fast forward how we were utilizing telehealth services, and it really has improved access. You can see our numbers in Centura on the right. We had a huge increase in appointments in 2020. And this really is remarkable because some of our counselors had very limited availability during the first part of the pandemic due to school changes and clinics shutting down, those types of things. So to see that much growth in a year was just huge. But what we kept hearing from our patients is these virtual services are allowing me to put my kids down for a nap and be seen for a health appointment. We saw many, many people from their offices or from a break, during a break in their workday. And many of our cancer patients, we could see them from home with their family members surrounding them. And it was just one less trip that they had to make to the hospital. So we are really hoping that this access to telehealth will continue. And that's something that we hope to see pushed forward as well. So my top 3 takeaways would be genetic testing has been significantly updated in recent years. So if you have any patients who were seen prior to 2015 or any individuals in your life who received just very targeted or limited testing, it's time for those folks to be referred back to genetic counseling for updated testing. Genetic counseling and testing is still really important, even if individuals test negative, so we can make sure that they're getting those personalized screening recommendations. And we need better access to genetic counselors. We need more of us. We can help to have better access by utilizing telehealth services, hopefully supporting the Access to Genetic Counselor Services Act, and continuing to show the need of genetic counselors in our organizations. So I will take some questions, but I wanted to make sure you all had these resources too. You can find genetic counselors near you with the findageneticcounselor.org website. There's great information on coloradocancergenetics.org, aboutgeneticcounselors.org, and the CDPHE group with the university genetic counselors put together this wonderful video. I use it in my clinic every day. Every patient who's scheduled with me gets sent this video, and Jean here does a great job of explaining cancer genetics, and it really sets the stage for patients of understanding, sets the foundation of their understanding of what hereditary cancer genetics is and what it means for them.
Thanks so much, Melissa. As Emily Kinsella is bringing up her slides, we did have a question come through in the chat, which is, can people refer themselves to genetic counseling, or do they need to be referred by their provider?
It really depends on the clinic. I would tell you at Centura, we require a referral so that we can order the genetic testing under that provider's name. And so we can communicate the results and recommendations back to someone who is managing that individual. I would tell you that if patients call us up and saying they want an appointment but don't have a referral yet, I can often send a referral request to that provider, making it easier for the patient.
Great. Well, thank you so much. And again, I'd encourage everyone to continue to put questions in the chat, and we'll make sure to address them and try to have some time to address some of them at the end. But please, please, please keep putting your questions in the chat so we can keep the conversation going, and we'll absolutely follow up with presenters as well if there's additional that don't get answered. So now I am going to turn it over, one second, to Emily Kinsella, who will be speaking about the Women's Wellness Connection Program, as well as the current guidelines and opportunities for synergies in Colorado between Women's Wellness Connection, as well as the other cancer screening programs. And one moment, I'm going to be sharing Emily's slides, but getting a bit of a delay. So one moment.
Do you need me to share them? I can. I thought it would be easier for you.
Emily, if you wouldn't mind sharing your slides, if you have them up, that would be great.
Okay.
It's been a fun day of technical difficulties.
Shoot. Okay, hold on. It's going to take me a minute too.
Here, I can try again.
I can do it. I have to do my notes as well. So hold on.
Sure, so sorry.
One moment, they're reloading for me. I can.
Can you see them?
Yes.
Looks good.
Okay. Okay, I'm going to look to the side now because my notes are on this side. So hi everybody, sorry for that technical difficulty. I'm going to try to go through mine a little bit quick because I know we're way behind. So I'm Emily Kinsella, and I am the section manager for the Women's Wellness Connection, which is the breast and cervical cancer screening program for the state at the state health department. So just a quick reminder, I think you all know this because you are cancer, hold on, I have 2 screens to do now, but you all are cancer professionals. So cancer is the leading cause of death in Colorado, ahead of heart disease, accidents, lung disease, and strokes. I'm going to talk a little bit about some data about breast and cervical cancer. So the incidence and mortality of breast cancer in Colorado has remained flat over the past decade. In 2018, over 4,000 women in Colorado were diagnosed with breast cancer and almost 600 died. I use 2018 data because that's the most recent data we have on this. The incidence was significantly higher in white women than all other races, and late stage diagnosis and mortality rates were highest among white women, followed by Black women. For screening, women who live in rural areas, have no insurance coverage, have no provider or established care, who smoke, who have less than 4-year degree, and are of low socioeconomic status are the groups that are significantly less likely to be up to date with mammogram screening. So very similar to the groups that Andy talked about for colorectal cancer screening. For cervical cancer, same thing. The incidence and mortality of cervical cancer has remained flat over the past decade. And the the diagnosis and death rate are much lower. So almost 200 women were diagnosed with cervical cancer and 32 died. The incidence, though, is highest among Asian Pacific Islander women, followed by white and Black women, and the mortality rate is higher among Hispanic women compared to non-Hispanic. Again, with screening, the younger and older age groups are the groups that are significantly less likely to have had a Pap test in the past 3 years than women in other age groups. And women with low socioeconomic status, no healthcare coverage, and no provider or established care are significantly less likely to be up to date with cervical cancer. So a little bit about the current screening guidelines for breast and cervical cancer. So the breast cancer guidelines haven't changed recently. The United States Preventive Services Task Force that we talked about, both Debbie, Dr. Dyer and Dr. Patel talked about, for breast cancer, they recommend routine mammograms every 2 years starting at age 50, and that mammography in clients 40 to 49 should be an individual decision. So these are the guidelines we follow for our Women's Wellness Connection services. But there is some disagreement and different guidelines from different organizations. So some guidelines recommend starting routine mammograms at age 40 or 45, and some guidelines recommend yearly mammograms instead of the annual or the every 2 years. But some of the things all of the guidelines agree on is that women 50 and older should be getting regular mammograms and at least every 2 years, if not sooner. And like Melissa just talked about, women should undergo a risk assessment to determine if they're high risk for breast cancer. Because as she, I think, pointed out really well, women who are at high risk need to be screened using different guidelines than average risk women. And of course, women with any symptoms or signs of breast cancer need to be seen by their physician or doctor. So cervical cancer screening guidelines, again, for average risk women. USPSTF says that for women ages 21 to 29, they should have a Pap test every 3 years. And then there's 3 options for women ages 30 to 65. Every 3 years with the Pap alone, every 5 years with HPV alone, or every 5 years with Pap and HPV co-testing, and then discontinue at age 65. The American Cancer Society did come out with new screening guidelines in 2020, and the big change there was they recommended no screening for average risk women under age 25. And then for women 25 to 65, their preferred screening is every 5 years with the primary HPV alone, but it's also acceptable to do the every 5 years with Pap and HPV co-testing. So again, the screening guidelines for cervical cancer agree on primary HPV or Pap and HPV co-testing for women 30 to 65, discontinuing at age 65. And I should have added here that they also agree that you should do screening. They just disagree what type for women ages 25 to 29. And again, women should be asked questions to determine if they're high risk for cervical cancer, because if they are, they need to be screened more frequently than average risk women. So the top 3 things to keep in mind. I'm going to go about, talk about the impact of COVID on cancer screening and diagnosis, tell you about House Bill 1913-01, and then tell you more about our cancer prevention and early detection in the Women's Wellness Connection program. So hopefully you all have seen some of this data and these slides over the past year, but really this shows that in the first 6 weeks of the pandemic, how quickly there was a decrease in cancer screenings for breast and cervical. I'm just going to kind of go through here, but there's lots of data just showing the decrease in screening due to clinics being closed, people wanting to minimize their risk, those kinds of things that really NCI showed that there would be 10,000 more breast and colorectal deaths over the next decade than they would have expected because of this decrease in screening. These come from the ACS Resuming Cancer Screening fact sheet, which is really helpful. Really basically say a variety of studies showed that in the spring of 2020, the number of cancer screenings dropped anywhere from 50 to 85%. And then a study found that diagnosis for the 6 major cancer types dropped by nearly 50%. And an estimated 12 million individuals lost their employer-sponsored health insurance coverage, with disproportionate impact on people who are Black or Hispanic. These were the takeaways from that fact sheet, which I thought were really key takeaways for everybody. So the reductions in healthcare access and cancer screening will result in a short-term drop in cancer diagnosis and a later corresponding increase in late-stage cancer diagnosis and preventable deaths. And that pandemic-related disruptions will likely exacerbate existing disparities in cancer screening and survival across groups of people who have systemically experienced social or economic obstacles to screening and cancer care. So in our program, we haven't seen cancer screening rates return to normal. I know that's different in different areas, but we have continued to see the screening rates be depressed compared to what they were before COVID. So the second thing I want to tell you about, and just make sure you're aware of, is House Bill 19-1301. So this was a bill that was passed in 2019 to expand coverage of additional breast cancer screening and imaging visits after an initial visit. And it applies to insurance policies and contracts issued or renewed on or after January 1st, 2021. So now, but it does not apply to Medicaid, Medicare, military plans, or self-insured employer-based health plans. So I added a link here for more information. And then the last thing I wanted to talk about, and I have a couple slides on this, is just tell you a little bit more about the Cancer Prevention Early Detection Women's Wellness Connection program. So you know a little bit more about what we're doing to address breast and cervical cancer in Colorado. So the community outreach strategy is our community level approach. The strategy provides education to individuals in the community about breast and cervical cancer prevention and early detection. And then it provides direct assistance to those women to access breast and cervical cancer screening service at a health system. This basically they're helping women identify their barriers to accessing screening and overcoming those barriers. We have 12 grantees doing this strategy. The clinic quality improvement strategy is our organizational level approach, and this strategy funds changes in clinic procedures, policies, protocols, and really increases the health system's capacity to systematically do cancer screening. The health systems implement evidence-based interventions that have been shown to increase cancer screening rates among clients. And then the last two are health navigation and clinical services strategy, which is known publicly as, and sort of historically, as Women's Wellness Connection. So it's that when people say Women's Wellness Connection, that's the part that they're thinking of. The health navigation component of the strategy is an interpersonal level approach, and it funds navigation of eligible low-income women into timely and complete breast and cervical cancer screening services. So it reduces disparities by helping eligible low-income women overcome their barriers. The clinical services component of the strategy is an individual level approach that funds breast and cervical cancer screening and diagnostic procedures for eligible low-income, uninsured or underinsured women. And it reduces disparities by reducing the out-of-pocket costs of screening for eligible women. So these are the eligibility criteria for that health navigation and clinical services eligibility. Women below 250% of the federal poverty level, lawfully present in the United States unless they're being served at a nonprofit charitable organization, which is about 2/3 of our clinics, because those clinics are exempt from the lawful presence verification requirements. They have to be 40 to 64 for breast services and 21 to 64 for cervical services. And then insurance status, if they're insured, they have navigation only, and then uninsured or underinsured would get navigation and clinical services. This is a map of where our clinics are located, our health navigation and clinical services across the state. And then the last thing I just wanted to tell you about is that we are re-releasing our request for applications. It's going to be specific to the health navigation and clinical services strategy. We're planning to release it in June, and only organizations that provide basic breast and cervical cancer screening services at their locations are eligible to apply. Current grantees do not need to apply, they're already funded. I have a link here to the website that we'll post information on, and on that website is also a form if you want to get on the distribution list to be notified when the funding opportunity comes out. And that's it for me. Thanks.
All right, awesome. I know Erin had a question that came up in the chat that she's going to be asking. And I believe right now, Chloe's going to moderate our next session, and where Elsa's bringing up the slides. Looks like our AV glitch is somewhat taken care of for a minute. So Erin, I will punt to you, and then Chloe will have you in the next panel get ready. So Emily, thank you a ton, but I know Erin has one other question for you.
Thank you so much, Emily. I enjoyed hearing more of the data from WWC. I was wondering, so how has COVID and the pandemic really impacted the roles of the health navigators that you fund? How have you seen that shift?
I think it's really emphasized the importance of health navigators. I think some of the barriers that clients are seeing it's either just made them even more present or added some new ones. Some things our navigators have reported seeing more of since COVID is food insecurity, childcare issues, things like that. Chris, Ivy, if you want to chime in more in the chat, feel free to do that. But yeah, I think that it's sort of elevated the need for navigation and also the just like explaining the protocols and what's happening and how the clinical services and various services and health systems are working under COVID.
Sure, all the changes with that. Thank you.
Great. So now I'm going to turn it over to Chloe Fields, who's the program manager for CCSP, who will be moderating our next panel and introducing Becky.
Thank you, Elsa, and thank you to all our previous presenters. In this next portion of our annual meeting, we are going to provide information from our Colorado Cancer partners in the areas that we work with. First, we have Becky Seelig, who is the Colorado Department, who's with the Colorado Department of Public Health and Environment, and she's going to talk about Colorado Cancer's plan and the efforts to move the needle forward. And then we have Mag Phillips, who's also with the Colorado Department of Public Health and Environment, and Mag will discuss Colorado Cancer program in Colorado. And lastly but not least, we have Allie Bain from the American Cancer Society, and Allie will discuss health equity and resources in Colorado. So Becky, I will hand it over to you. As mentioned, we encourage you all to provide questions in the chat for our presenters over this next section. Thank you.
Great, thank you. Can you hear me okay?
Yes, we hear you perfectly.
Perfect. Great. As Chloe said, my name is Becky Seelig. I'm with the Comprehensive Cancer Program at CDPHE, and you can advance the slide, please. So just a brief overview of the Comprehensive Cancer Program for those who aren't familiar with it. We receive funding from the CDC. There are 65 total funded programs. All states, DC, some territories, and tribes receive funding. Priorities for the program are aligned with continuum of care and include developing and implementing a state cancer plan, supporting the Colorado Cancer Coalition to prioritize efforts, increasing collaboration, building relationships, and expanding partnerships. So as you see on here, our current work plan includes strategies to decrease obesity, increase HPV vaccination, increase colorectal and lung cancer screening rates, and then working in the survivorship realm to improve post-diagnosis care and increase access to palliative care. Next slide. So as I mentioned, one of our responsibilities is to implement a cancer plan. So the Colorado Cancer Plan is our statewide roadmap for decreasing the cancer burden in Colorado. We are currently in the process of revising our 2021 to 2025 cancer plan, which will be launched in July. And I know many folks on this call have been instrumental in helping to revise the plan. So next slide. So we will have more information about the plan in the coming months, but just a quick overview. It will include 9 goals and 28 objectives across the continuum of care, and it will include suggested evidence-based strategies for each of the objectives. So you can see here, these are the 9 goals that will be included in the plan, and a lot of the work that folks on this call are focusing on are in the screening and early detection, goal number 5, to increase cancer screening and early detection rates. Next slide. So the bulk of our cancer plan implementation work takes place through the Colorado Cancer Coalition. For those who are not familiar with the coalition, it is our statewide network dedicated to improving Colorado lives touched by cancer. And it includes members just like you all who are interested in working more efficiently and effectively together. So anybody who is interested in joining us in our work is welcome to join us. There's no cost or anything to be involved. So we welcome as many folks as are interested. So next slide. The coalition is made up of task forces, which is where a lot of our work happens. So we currently have 5 active task forces. Colorectal cancer has 3 work groups, so working on provider support, employers, and doing some awareness work for March and beyond. The lung cancer task force is currently working on planning their 2nd lung cancer symposium, which will take place on November 3rd. The Skin Cancer Task Force is working on supporting the Sun Bus and other awareness events, and also collaborating with other of the specific cancer sites to increase awareness around screenings. And then we have the Survivorship and Palliative Care Work Group and the HPV Vaccination Work Group or Task Force. And we're in conversations about starting up a treatment and clinical trials task force. So hopefully we'll have more information to share about that. And if you don't see a task force mentioned here, it's just because we don't have folks quite yet ready to take the lead on something, but we're always open and willing to have conversations if there's something that you are not seeing here that you would like to help move forward. And we would welcome anybody who would like to participate in any of these task forces. You can just get on the email list so you can stay informed of work that's going on, or you can join the monthly meetings. But we welcome participation in whatever way works for you. Next slide. And then a few other programs and resources that might be of interest to folks on the call include a monthly peer sharing series. So it's rotating topics of interest. And if you have a topic in mind that you'd like to learn more about, let us know. It meets on the 3rd Wednesday of the month at 11:30. And it tends to just be small groups who share best practices and are able to ask questions and learn from each other. So hopefully you can join us for some of those. And then the coalition also offers a wide range of webinars. Many of those are led by the task forces that I mentioned. We have live and previously recorded webinars available for you to peruse at your convenience. And then next slide. And then a few other resources I wanted to make sure folks knew about. We have a support groups in education Google sheet that's available. I know Christy is sharing these links into the chat. This provides information. As you see, there's a set of tabs at the bottom of that image where you can bounce around between specific types of support groups and education opportunities. So hopefully you can find that useful as you're doing your work with your patients and partners. And then next slide. Similar to the one I just shared is resources for patients and caregivers. So again, we started this during COVID, and some of it might be a little bit out of date, but still wanted to share it with you. Again, there's tabs on the bottom for resources about cancer and COVID, United Way, national support programs, transportation assistance, and so forth. So hopefully you'll find some helpful information on there. And if you see things that are missing, please reach out and let us know. Next slide. And then lastly, I wanted to share, this is the cancer resources map. So this is a relatively new partnership that we have with the University of Colorado Cancer Center. And it's a interactive map that you can use. There's a video tutorial that you can watch to learn how to use the map. And then there's different categories, as you see on the far left there, that you can click on for low and no cost cancer screenings, genetic counseling and testing, and so forth. And essentially, when you click on each of those, it'll bring up a map and you can see where some of those resources are located. And then a pop-up box will pop up, as you see here, for Mercy Regional Medical Center that gives some contact information. So this is a work in progress, and we're going to continue to expand on this map, but we hope that it can be a resource for you and those that you work with. And we welcome feedback on that as well. So please take a look and let us know how we can improve that resource. Next slide. So that is all. I shared quite a bit of information. Just wanted to get it out there, but you can join us at coloradocancercoalition.org. Like I said, we'd love to have more folks join the work that we're doing. And if you have any more questions, I'm happy to help answer. And I put Christy Cahill's information up here as well. She's the executive director of Cancer Coalition. She'll be speaking later. So that is it. And I will pass it over to Meg, who will speak about colorectal cancer.
Thanks, Becky. Can you hear me okay?
Yes.
Great. All right. My name is Megan Phillips. Like Chloe had mentioned, I'm the Colorectal Cancer Control Program Manager at the Colorado Department of Public Health and Environment. I'm going to go through my slides pretty quickly. A lot of what Becky had talked about and what Emily had talked about kind of covers our colorectal cancer control program. So next slide. So the CRCCP program has been a funding opportunity through the CDC since 2005. This is a competitive funding opportunity, so it's not guaranteed to every state. So we have to compete with other health departments, universities around the country in order to receive this type of funding in Colorado. All of this funding has really been centered around clinic quality improvement and implementing evidence-based interventions for increasing colorectal cancer screening within health systems. Next slide. So we received our most recent round of funding, which is very exciting, in June of 2020. So we're a year in, and we are almost a year in. This is 5 years worth of funding, and we are one of the 19 state health departments that receive this funding, really to focus on a few different priority strategies for evidence-based interventions, which include provider assessment and feedback, provider reminders, removing structural barriers, and then patient reminders to increase screening. Next slide. Like I said, the majority of this funding is really focused around health system change. So clinic quality improvement is a large portion of our funding, and that really kind of ties into Emily's presentation earlier as a part of the Cancer Prevention and Early Detection Program, or CPED. We also have a new strategy that allows us to help facilitate access to follow-up colonoscopies within the clinics that are implementing evidence-based interventions within the CRCCP program. So this also looks a lot like building partnerships and collaborations on how we best access follow-up colonoscopies after a positive stool-based test. slide. So knowing that this is really competitive funding and we really only have 5 years to do this work, a lot of this is also focused around sustainable health system changes, which is why clinical quality improvement seems to be the best hat to do this work in. Implementing those system changes, spreading them throughout the whole health system, making sure that we're impacting all aspects of the patients that our partners serve, not only so that they get timely information about cancer screening, but also have the right decision-making tools to choose the best test for them, which is the one that gets done. And then having that little bit of funding to help support partnership building surrounding follow-up colonoscopy access is also, I feel like, a really great kind of bookend to how we should be doing this work with a sustainable lens in Colorado. Next slide. So Andy had showed this map a little bit earlier. We're in the process of updating this, but it goes to show kind of how we look to potentially focus our efforts and identify partners based off of screening rates within the state, populations that need the most help in terms of access, but also late stage colorectal cancer. Next slide. So Emily had covered this in her presentation, so this should be nothing new, but we have a wonderful program called the Cancer Prevention and Early Detection Program that really combines the National Breast Cancer and Early National Breast and Cervical Cancer and Early Detection Program, or that Women's Wellness Connection funding, with our colorectal cancer funding, knowing that CQI is really an aspect that we should be doing in both breast cancer, cervical cancer, and colorectal cancer. So with those two funding sources combined, there's that creates the Cancer Prevention and Early Detection Program. So it allows us for a more unified approach in terms of doing this work, but also decreasing the administrative burden for partners that maybe are doing breast cancer and cervical cancer work with colorectal. Next slide. Like I said, this is really focused around increasing screening, reducing morbidity and mortality rates. Our partners are able to select different strategies that they're interested in, like the outreach strategy, health navigation and clinical services, and also clinical quality improvement. The more collaborative and unified approach to do this work. It also reduces the number of contracts that maybe are for similar work that come out of CDPHE. So it's a very comprehensive approach to increasing cancer screening in Colorado. Next slide. So Becky and I had talked a little bit about, when we were making our slides, what are the top 3 things that we should be keeping in mind about cancer screening, not only from the coalition, but also in our work at CDPHE in the time of COVID. And the 3 that we came up with were collaborate whenever possible, leverage available resources, and think outside of the box in terms of how we're getting patients across the line to complete cancer screening. So this is, I think, a really timely presentation, and thank you CCSP for allowing me to take up a little bit of the time to talk about our program and the work that we're doing. I think that's it for me. Oh, and here's my contact information if you have any more questions about our colorectal cancer control program at CDPHE. Thanks.
Thank you so much, Becky and Mac, for that wonderful information. We have no questions at the moment, so I'm going to move it on over to Allie, if you're ready.
Yeah,
Allie's going to talk about health equity and resources in Colorado.
Can you hear me, Chloe?
Yes.
Awesome. So like Chloe mentioned, I'm going to talk a little bit about the health equity work that ACS is doing around return to screening and some of the resources that are newly available, kind of hot off the press, that I'm excited to share. So I'm Allie Bain. I'm a Cancer Control Strategic Partnerships Manager here in Colorado. And I've done some presentations for this group before, but hopefully all of this is new and exciting for everyone. So you can go to the next slide, Elsa. So as Emily mentioned in her presentation, we really did see a huge drop in lung, breast, and colorectal cancer screening due to COVID. And whenever we weren't doing any necessary services. So this has had a huge impact on our work, and ACS is really focusing now on getting folks in back for screening and supporting clinics with the resuming screening process. So next slide. And then we also have, oh, sorry that that's not showing up very well. So we also have that screening disparities and the impacts of COVID, knowing that 12 million people lost their health insurance, including 5 million that were Black and Hispanic, which Emily also mentioned. And so we know that screening rates are typically 40 to 50% lower in uninsured populations. And then there's additional barriers. If you have to decide if you're going to pay your rent or get a colonoscopy, it's pretty obvious which one you will choose. So what is ACS doing to address this cancer screening crisis and kind of this health equity and these huge disparities that have been created? So next slide. So for ACS and ACS CAN, we have really created a definition of health equity as everyone has a fair and just opportunity to prevent, find, treat, and survive cancer. And within this definition, we really emphasize that equity does not mean equality. We know that different folks need different tools, that there are different things that we need to do to make sure that people can access screenings and can get the quality care that they need. So through this, we have adopted our health equity principles, which include people, place, and partnerships. So next slide. And so this is what this kind of looks like for our work for a comprehensive approach to health equity. So we realize that we need to help people with the greatest need, embrace diversity, collaborate with community members, understand why some of these disparities exist from some of these long-standing injustices. We need to implement sustainable solutions. We've heard about that today with the need for sustainability with the CCSP program. Addressing social determinants of health, again, if folks don't have housing or don't have food, knowing that that's more likely a concern than cancer screening. We need to prevent and address unintended consequences, partner with different sectors, and leverage the power of volunteers. So one example of what this looks like is some of our health systems work. So this is kind of our new strategy for 2021, although we have been doing some of this work historically as well. So we're planning, we are rolling out some technical assistance resources. Emily mentioned some of the fact sheets that we have already distributed. We really are emphasizing working with underserved communities and to reduce barriers, especially those that have been exacerbated by the pandemic, implementing evidence-based interventions. So we're working with Meg and her team to provide some support to clinics across the state, and creating learning communities. So we know that there are some opportunities to bring folks together to share, much like the coalition is doing with their peer sharing calls. So ACS is happy to support that. Utilizing data, and then again, with sustainability. So next slide. And then some more kind of specific examples around this is we're creating some opportunities to develop learning collaboratives. So rather than working with one clinic one-on-one, we're bringing multiple clinics together to share information more widely, and then also allow clinics to learn from each other. And we're also working with some national partners to provide some funding support. So we're not exactly sure what that looks like, but hopefully in the coming weeks and months, we'll have more information about what some of those partnerships look like. So now on to the resources. So like I said, these are very hot off the press. So we have 2 different guidebooks that have messaging specifically around the pandemic. And It's based on research that ACS did to determine what messages really resonate with people to help get them back in for the screening that they may have missed in 2020 or that they're just due for. And so when these slides are shared, that available here, link will link to those guidebooks. And then very exciting, the rest of these resources were just released on Monday. So again, good timing with the meeting planning. Elsa, if you just kind of want to click through these, there's a whole bunch of different things. So there's flyers, there's PSAs, there are some that are audio, there are some that are digital, there are print ads, social media ads, banners, letter templates. I would definitely say that this is one of the biggest messaging campaigns that I have seen ACS do. So it's really exciting to be a part of. So most of these are available on our website at cancer.org/get-screened that you can see on a lot of these slides. And then in addition, it will give you access to our brand toolkit where you can download them too. So if you have any questions about where to find something or yeah, reminder cards, I didn't mention that. That's been mentioned a couple of times today, but we really have created this great comprehensive messaging campaign that'll be really exciting. And also exciting, this is just phase one of it. So there'll be more great things to come that I will be sure to share as soon as they're available. So here's my contact information. Like I said, we went through those slides really quick. I think when I sent Chloe a 30 slide deck for a 6-minute presentation, she probably had a little bit of a heart attack. But when the slides are shared, you guys can look a little more closely at all those different resources, and certainly let me know if you have any questions or if you have any trouble finding something that you're looking for.
Thank you so much, Allie, and thank you, Becky and Mac, for your presentations. We really appreciate it. We don't have any questions at the moment, but we definitely encourage you to put them in the chat if you have them. We're going to move forward with our meeting today. I'm going to pass it over to Andy, who is our CCSP director, and she will be moderating our next 2 sections. And there you go, Andy.
All right, awesome. Thank you so much, Chloe and team. So again, I'm bringing my raspy, very sensual voice today with my clogged up face, so please bear with me. I'd really like to spend the rest of the time that we have today, and we will end at 11:30, but we're going to hear from our partners from Colorado Community Health Network, as well as Colorado Rural Health Center, who've been also integral in really thinking about engagement of the safety net over the last 15 years. Essentially, to think about the implementation of CCSP. I know partner with the health department for the CPED WWC, as well as a number of programs and partnerships with ACS and others. And again, I think that umbrella of doing work under the Colorado Cancer Coalition, which Christy's going to round us out today, is still imperative. But I just want to talk from our network partners and who are serving that primary care association capacity, a couple of key questions. So one, I think number one, I want to hear from Taylor and Katie and Natalie a little bit. We'll have you introduce when you respond to the question. But number one, with what we've seen, different parts of CCSP where we saw no screening, I think the statistics that Ali showed, as well as Swati and Emily, we definitely saw a period of time where we kind of flatlined with screening. CCSP, we saw an upward trajectory and it's kind of ebbed and flowed. I want to get some response from you all about if you've seen that through other programs, treatment, that kind of work. And then second off, how you guys are responding to what you're hearing today and what are our next steps forward in supporting clinic systems. So Taylor, I'll start with you around, that impact of COVID and kind of that general response of what you're thinking and that response to where we're going next.
Yeah, thanks, Andy. So I'm Taylor Miranda Thompson. I'm the Senior Quality Initiatives Manager at CCHN. And yeah, I think it's no surprise that it's been a really difficult year and continues to be a difficult year. When we aggregated our state data for 2020, we saw about a 5% drop in cervical cancer screening, about 2.5% drop in colorectal screening, and about a 2% drop in our tobacco cessation measure. So while we do see our measures kind of ebb and flow year to year, this year we really predicted a drop and saw a bit of a drop. But just kind of reflecting on that, I think when we think about the strategies that we use for each of these types of screenings, cervical cancer being the most common in-house service, and we saw, the most significant reduction there, and pause of in-person services during the pandemic for wellness visits. I think that makes sense. And, we have other strategies for colorectal and tobacco screening that can be done, outside of your typical visit. So for us, I think, and we don't know for sure that that's the direct correlation there, but we can make some kind of assumptions. And I think that just speaks to the value of kind of having those non-traditional strategies, navigation, your flu fit, your mail-based things, telehealth. So yeah, I think, we definitely saw that as a result of the pandemic, and thinking about what are the strategies that we can use to support our clinics to kind of get through those.
Great. What about our Colorado Rural Health Center team?
Yeah, so hi everyone. Thanks for having us, Andy. I'm Natalie Krause. I'm the Associate Director of Programs at the Colorado Rural Health Center. I think, definitely we mainly work with the rural health clinics and the critical access hospitals across the state. I think, at the onset of the public health emergency, we definitely saw utilization was really low for both our hospitals and our clinics. And while we've seen, visits increase and even in some cases get back to where they were pre-pandemic, we still know that along with like the vaccine hesitancy, which I think we're hearing a lot about in rural communities, is just kind of the general hesitancy of these patients to return to their primary care provider or even to the hospital. And I'll let Katie speak to this a little bit, but we deal with a lot of programs that are helping manage, patients with multiple chronic conditions. And one of the big concerns there is that they're not coming into the clinic, not coming into the hospital, and then not receiving the needed care that that they need to be able to manage those diseases. And that includes patients with, cancer that live in rural areas, right? And so I think we really want to focus on what can we do in terms of innovative models. And you guys have touched on a lot of great things today, really focusing on like the focus on patient navigation, what we can do with telehealth moving forward, because I don't think that, this kind of hesitancy is just going to go away, right? There is now this stigma associated with a public health emergency, and just knowing that something like this can happen. And I think it's a barrier that we're going to have to overcome with patients. And we really want to work with the hospitals and the clinics to really find opportunities of what are some, workforce we can lean on, as well as things like telehealth that we can do to make sure that these, routine screenings and these necessary visits are still happening, even with that kind of fear and hesitancy in the patient population. And I'll let Katie kind of talk about that too, in terms of some of the things that we've been looking at with grants and projects that we're working on.
Yeah, great. Hi, I'm Katie Schweber. I'm the Quality Improvement Specialist at Colorado Rural Health Center. And yeah, one of the programs we're doing through CRHC is chronic care management. And chronic care management, or CCM, really allows the primary care providers to support their patients who have multiple chronic disease through monthly touch points and other support services, and then to get reimbursed for their time spent doing that. So we have found that it is a pretty sustainable model so far. And during our year-long program, we help rural clinics establish their chronic care management program by providing technical assistance to establish their team, the different components of chronic care management, and those processes. And like Natalie was saying, and we are, really looking at how care coordinators are involved with that, and even community health workers, I think, is a really exciting position to be able to pull into chronic care management, to explore that a little bit more. And yeah, some of our clinics have literally just implemented their chronic care management program. They have one kind of test patient right now, and another one we're working with was able to really focus on the program they already had and increase it from about 40 patients to about 100. So I think there's a lot of opportunities there to give them education about specific diseases and self-management techniques, and things like that.
Yeah, that's awesome. which I think really does help, like you were talking, Natalie, really blend a lot of the themes and ideas that we were talking about in resources. And we'll continue to work with all of you to think about those types of opportunities. You know, and I think, Taylor, queuing you up for kind of our final thought from you, and then we'll move to Christy and round out our day. You know, CCSP is really a 2-year extension after this year. We're really thinking about, and, you know, we talked about that sustainability of navigation, preventive cancer screening. You know, I think the CPED WWC program and other efforts will live on, and we're really thinking about that integration of navigation and CHW work. So Taylor, at that intersect with the work you're all doing with CCHN as well, is there any specific initiatives that you really think will help bolster that activity? I think Rural Health Center talked about that, but you guys are also really doing a lot of engagement in that area as well. Do you want to give us a glimpse of that? And then we'll transition to Christy and my ode to make sure that we end at 11:30 today.
Yeah, Andy, I think that's a great question. I think, you know, we'd love to see navigators have the ability to bill. But aside from that, you know, I think our focus for the next year or so is going to be really thinking about these guidelines as they change, how to help clinics operationalize them, you know, adjusting workflows, staff education, navigator education, patient education and messaging, and just how to incorporate better data around where the disparities exist, as Ali mentioned. So I think, you know, that's really where we'll be moving and what we'd like to see over the next year. Thanks for all the presentations today.
Great. And I do think, you know, we are having some discussions with HICPUF. I know that a number of our policymakers are considering at the federal, state level, how do we really look at this? I think CHWs and really navigators, and I know there's starting to be more apprenticeship and opportunity for buildup of workforce. Our partners for PNTC, which Erin is with us today, thinking about this integration. But I do think, again, that CQI, the guideline component in keeping cancer prevention, where we really actually see some of the strongest outcomes for navigation and being able to show that sort of connection to clinical work, access to care, the resources that are mentioned from our state health department, cancer plan, and that management is, as well as ACS and all the providers who really are behind this work and championing it are going to be key. So to that, Christy, I'll give you the final little bit to talk a little bit about this umbrella of the Cancer Coalition and really that elevation of return to care as we wind out today.
Great, thank you, Andy. Can you all see my slide?
Yes.
All right. So I'm just super excited to be here today and see everyone that's here. We will be launching a statewide, or we are launching today, the Return to Cancer Screening campaign. So really to work on, you know, everything we're talking about here. We'll be better off together if our messaging is the same, you know, starting from the same, and then we can tweak it for our different audiences so it's culturally relevant. But really working together to get people back in for all the screenings that they're due for. So I just posted in the chat a lot of different opportunities where we'll be continuing this discussion. So Ali will be joining us again to talk about evidence-based interventions in June. You can learn all about who the regional health connectors are and what they can do for you through CCSP. They're hosting that webinar. We'll be talking more in depth about the updated lung cancer screening guidelines, and then we'll be launching I have those dates wrong, the 21 to 2025 cancer plan in July. We've got our lung cancer symposium coming up, and then the annual symposium for the coalition, where the focus is going to be the time is now, get everyone back in the door, work together so that, you know, we can hopefully change it so that cancer is not the leading cause of death in Colorado. So let's figure out how we can all work together and get people back in the door. So thank you for joining us today. Andy, I'll turn it back to you.
Okay, great. And then I do want to also note that through, I think, CCSP's programming in the year ahead, as well as I know WWC, as well as the Cancer Coalition, we'll be starting to delve in and unpack some of the things that were brought up today. We did want to give a glimpse of the guideline changes, what it meant for inclusivity around cancer prevention, navigation. But again, in the spirit of trying to keep things shorter because of Zoom fatigue and where we all are right now with our work and life balance, working at home and the like, we wanted to really just provide some key insights. But I do think partnerships are key. And I know there were a lot of people around the table today that shared some perspective and prerogative. We're going to continue to build those relationships. And so for anyone who's new, as well as people who are part of our clinic systems, partner systems. We really do want to continue this tight-knit opportunity to continue our work together. And again, on behalf of the CCSP program, we are going to be still really rolling out some great opportunities. We actually even have more resources than we've had for the last 3 years to build upon that lung cancer work, the genetic and hereditary work that Melissa talked about, more opportunities for resource building, capacity building in this area, and even for our colorectal cancer component that's been the mainstay, that navigation dollars, but even deeper implementation around stool-based testing to try to meet the equitable need that Swati spoke of, others spoke of, and really thinking about resources in that area to really amplify this work. And have always enjoyed and really modeled a lot of our work after the CPED WWC team, and excited this federal dollars for CRCP as well as other programs are instrumental. I do think federal partners like ACS and others have great return to screening campaign. So excited about the amount of resources that are being pushed out. So really thinking about how we integrate that. And again, we have 2 more years for this specific program. It's really going to be on so many of you to help continue this legacy. So excited about the next 2 years and how we really move this ahead. Thank you so much for joining today. And we will continue the conversation with all of you throughout the next year and beyond. So have a great day, and a huge thank you to Chloe and Elsa, who really helped put in the time for the coordination and pulling this together, as well as Erin Martinez, who helped, Betsy Rizendahl, who's been a team lead for us as well for implementing CCSP with a number of people like Dr. Anand, as well as Holly Wolf, Tim Byers, and others who've really helped champion the work. So have a great day. Happy Friday, everybody. And I'm going to have another Zyrtec to store whatever the whatever that allergy medicine is. So have a great day. Thank you so much for your time. And I know Chloe did provide a link for evaluation. So have a great day. Thanks so much.